Hello, good afternoon. My name is DJ Lakreddy. I'm one of the co-founders for the. Good afternoon. My name is DJ Lakreddy. I'm one of the co-founders. All right, I'm going to restart this. Hello, good afternoon. My name is DJ Lakreddy. I'm one of the co-founders for the Global Atrial Fibrillation Alliance, and I welcome you to this educational symposium on atrial fibrillation on the World AFIB Awareness Day. It was exactly 10 years ago that the governor of Kansas in 2010 has officially proclaimed the second Saturday of September as the World AFib Awareness Day. And this proclamation has been reciprocated by many other states thereafter. So as you're aware, atrial fibrillation is one of the most common cardiovascular conditions that affects human beings. And this is rapidly growing. Currently, there are about 5 million Americans that are affected by this, and there are more than 60 million people across the world that may have atrial fibrillation, and this number is deemed to double over the next decade. So all of a sudden, we have a global pandemic at our hand, in a sense, that we have to learn more about and be able to tackle this. And there are many things that need to be done, both from the physicians and healthcare system standpoint, but there is an equal amount of learning and prevention that needs to happen from you all as patients, or from us all as a human civilization. So in today's discussions, we have focused on improving our understanding of the pathophysiology, the clinical impact of this arrhythmia, and the currently available treatment options, and some of the latest surgical technologies that are available in treating these arrhythmias, and above and beyond means of minimizing and preventing this arrhythmia by modifying the risk factors. We have a very distinguished faculty today from the Kansas City region. We have Dr. Alap Shah, who is one of the members of the Kansas City Heart Rhythm Institute, Dr. Ria Pimentel from the University of Kansas Hospital, and Dr. Sanjay Gupta from St. Luke's Health System, and also Dr. Scott Kerber from the Kansas City Heart Rhythm Institute, who will be discussing about various aspects of atrial fibrillation. And at the end, we have a question and answer session that is moderated. So with that, I welcome you to the World AFib Awareness Day education event, September 12, 2020. Thank you.
This is Sanjay Gupta from St. Luke's Mid-America Heart Institute. I'm here today to talk to you about risk factors for developing atrial fibrillation. Atrial fibrillation is the most common heart rhythm abnormality in the world. It's characterized by a rapid, irregular heartbeat from the atria, which are the top chambers of the heart. As you can see in the video here, the top chambers are quivering several hundred times a minute, causing the bottom chambers to race rapidly and irregularly. All this chaotic and rapid activity is manifest in the electrocardiogram, which is shown at the bottom of the screen. The reason we fear atrial fibrillation is that it increases risk of stroke by 5-fold. It triples the risk of developing congestive heart failure and doubles the risk of developing dementia. This slide is a little out of date, but it gives you the basic idea that basically there are currently about 6 to 7 million people in the United States with atrial fibrillation and about 5 to 6 million people in Europe. The rest of it is accurate, and it is expected that the prevalence of patients with atrial fibrillation will double by the year 2050. One in 4 adults over age 40 will develop atrial fibrillation in their lifetime, and overall about 2% of the world is affected by atrial fibrillation, about 140 million people. The biggest risk factor for developing atrial fibrillation is just age. Sometimes patients may not have any other medical conditions other than age, and they can develop atrial fibrillation. Typically, it starts to appear after age 60. The symptoms of atrial fibrillation are highly variable, most common of which is fatigue, which some patients may just misinterpret as just, quote, getting older. But other patients are more aware of different symptoms such as heart skipping or a racing heartbeat. Having high blood pressure is another risk factor for developing atrial fibrillation. The blood pressure guidelines were recently revised by the American Heart Association, and the new goal is to get a blood pressure of 120 over 80 or less. High blood pressure could be asymptomatic, and so it's important to check regularly. Everyone should have a home blood pressure cuff like shown here in the diagram. You should get the one that fits on the arm and that has a digital scale that's more accurate and also has a memory that will keep track of your readings. Just as important as taking your blood pressure is having good technique. It's important to take your blood pressure when you've been sitting down at rest for at least 5 minutes. You shouldn't be eating, talking to someone, or drinking caffeine or alcohol. Try to do it about the same time every day. I generally recommend my patients to check their blood pressure about an hour after their morning medications, just after they finish eating breakfast, before they get up from the breakfast table. Congestive heart failure is another condition that can be a risk factor for developing atrial fibrillation. As shown in the picture, you have normal heart function on the left and then congestive heart failure on the right. It can be caused by either a weakening of the heart muscle, as shown in the diagram, which the heart fails to contract enough, versus a different condition whereby the heart can actually contract fine but has difficulty in relaxing. Both of these are different forms of congestive heart failure. Symptoms can include shortness of breath, fatigue, or weight gain. It can be diagnosed by an echocardiogram. That echocardiogram will give a number called the ejection fraction, which is the most important number to know from that study. This calculates the percentage of blood pumped out with each heartbeat. A normal ejection fraction is between 50 to 70%. That's normal. So if your ejection fraction is less than 50%, that means it is reduced and you may have congestive heart failure. Heart valve disease is another risk factor for developing atrial fibrillation. This can be a result of valve narrowing or thickening of the leaflets, or valve leaking or dilating. Most commonly, we're talking about the mitral valve, which separates the left upper chamber from the left lower chamber, but it can also involve the aortic valve, which separates the left lower chamber from the aorta. The symptoms of heart valve disease are very similar to congestive heart failure and can include shortness of breath, fatigue, and weight gain. It can also be diagnosed by an echocardiogram. If the valve dysfunction is severe, it may require a surgeon to replace or repair the valve, or it can also potentially be repaired by a catheter procedure with a cardiologist. The picture on the top right shows rheumatic mitral valve disease, which leading to a narrowing of the mitral valve, and on the bottom left shows mitral regurgitation, a leaky valve that allows blood to flow back up in the left part of the heart. Both these can lead to atrial fibrillation. Another risk factor is diabetes. This can be either type 1, which manifests in childhood, or type 2, which appears in adulthood. The symptoms of diabetes include excess thirst and urination, fatigue, and weight loss. It can be diagnosed by blood tests, and you may require treatment with insulin or oral medication. Coronary artery disease is the disease that leads to heart attacks, and this can also lead to atrial fibrillation as well. This can either be mild or it can be major to the point where there's a severe heart attack. The symptoms of coronary artery disease are chest pain or pressure, a term we call angina, that can also move from that area to the left arm or jaw. It is typically diagnosed by an electrocardiogram or EKG, blood test, or a stress test. Treatment may involve medication or a stent placed in a catheter delivered from an artery in the wrist or the groin into the heart. Other risk factors for developing atrial fibrillation include thyroid disease, which could either be too high or too low. Typically, the symptoms of having elevated thyroid include palpitations or skipped beats or racing heartbeats, fatigue, diarrhea, or weight loss. It can also be diagnosed by blood tests, and treatment may require medication for life and testing at regular intervals to ensure the treatment is adequate. And finally, there are other medical factors that could also be contributing to atrial fibrillation, including emphysema or COPD. There's a condition that leads to inflammation of lining around the heart called pericarditis that sometimes can be caused by a virus, and this can also lead to atrial fibrillation. And then atrial fibrillation can also be seen following open heart surgery or after a serious illness or infection like a pneumonia. as shown in the pictures on the right. These are all the medical conditions, but there are also several modifiable lifestyle factors for developing atrial fibrillation. The far and away the most common is sleep apnea, a condition where people stop breathing when they sleep. The most common version of sleep apnea is obstructive sleep apnea, which is typically seen in men who are overweight, and this is caused by soft tissue collapsing around the upper airway, leading to a narrowing of that airway. Initially, this causes snoring, but eventually, as that process continues, the airway completely closes off and the patient will stop breathing. In contrast, central sleep apnea is much less common, but is equally as problematic. It is caused by a lack of the brain sending signals to the diaphragm breathing muscle telling it to breathe, and patients will intermittently just stop breathing during the night while they sleep. It's important to screen for symptoms of sleep apnea, and these can include fatigue, drowsiness or daytime sleepiness, or snoring. Alcohol use is another leading risk factor for developing atrial fibrillation. Many patients will experience atrial fibrillation just with normal recreational alcohol use. For patients who are at risk for developing atrial fibrillation, I recommend decreasing alcohol as much as you can, and I tell my patients to get down to as little as possible, but generally no more than 1 drink per night, no more than 1 night per week. And finally, being obese is another risk factor for developing atrial fibrillation. Whether you're in the overweight, obese, or morbidly obese category, all of these significantly raise risk of developing atrial fibrillation by either directly increasing risk or indirectly through increasing risk of developing sleep apnea. So what can you do to reduce your risk of atrial fibrillation or to prevent from getting it? Focus on the modifiable risk factors. So if you've never been tested for sleep apnea and you have symptoms that are suggestive, I recommend you get tested. Try to reduce your alcohol consumption to as little as possible. Try to reduce your weight through diet and exercise. You don't have to lose all your weight if you're overweight. Just if you can lose even just 10% of the body weight, that significantly reduces your risk of developing atrial fibrillation. Finally, keep track of your blood pressures and keep track of your medications, and bring these in to see when you see your doctor. Maintain regular medical follow-up with your providers and with any scheduled diagnostic testing. Thank you for your attention. Feel free to email me if you have any questions.
All right, thanks, DJ, for the opportunity to share in this discussion. My name is Dr. Scott Kerber. I'm one of the heart rhythm doctors for Kansas City Heart Rhythm Institute. And today we're just going to talk briefly about some treatment options that are available to you once you've been diagnosed with atrial fibrillation. So first, let's just review briefly what AFib is and what it does to the body. It's mainly a rhythm that causes some irregular heartbeats in the top chambers of the heart. So if you picture your heart, you have the 2 top chambers here and the 2 bottom chambers. The normal heartbeat originates up here, called the sinus node, and that beats automatically. And that signal then spreads to the top 2 chambers and makes the top 2 chambers beat rhythmically like this. Then that signal then spreads to the bottom chambers and makes the bottom chambers beat. So a typical heartbeat is top, then bottom, top, then bottom. What happens in atrial fibrillation is there's some extra beat, particularly coming from the left atrium over here on this side, that is firing, called a premature atrial contraction. So it's an extra beat that's coming in and really disorganizing and making the top 2 chambers beat in a really chaotic rhythm. And so this slide here will demonstrate this. There's normal, and there's an extra beat, and then the top 2 chambers get into a really chaotic rhythm, and it causes a couple of different problems. So the main clinical problems that we worry about with atrial fibrillation, the first one is a stroke. And so the top 2 chambers, instead of beating normally and rhythmically and squeezing the blood out of the top chambers, they're quivering. And so blood can actually pool in that top chamber up here and cause a blood clot and therefore stroke. So that's why you see all these commercials on TV about different blood thinners such as Eliquis, Xarelto, Pradaxa, Savasa, warfarin, things like that, that the goal is to thin the blood in order to prevent blood clots and therefore stroke. Another problem that happens with AFib is a lot of those electrical signals that you could see here in this demonstration that we just saw. A lot of those electrical signals can go down and make the heart beat really fast and irregular, and that can give you symptoms of palpitations, fatigue. It can feel like your heart's racing, and other symptoms that we'll get into just a little bit later. The premise behind atrial fibrillation is that these extra beats that are coming in, particularly like we talked about from these veins. So if you picture the room that you're sitting in as your left atrium, this chamber right here, and then picture 4 hallways coming in the backside, something in those hallways is usually being obnoxious and getting out into the pot and stirring up the rhythm. And so that's the premise behind AFib, and then we can talk about different ways to treat it. So there's 2 basic treatment arms for atrial fibrillation. The first one we're going to talk about is rate control, and that's where we say, who cares if you have AFib? As long as we can control the ventricular rates, meaning how many of those electrical signals can go down and make the bottom chambers beat really fast and irregular, as long as we can control how frequently those bottom chambers beat, and in addition to giving you blood thinners to prevent stroke, that's an acceptable way, particularly in patients that are asymptomatic, meaning they can't tell when they're in AFib, they have no symptoms of palpitations, shortness of breath, fatigue, but they still are at a risk of stroke. And so the treatment option of rate control and stroke prevention with blood thinners is an acceptable option. The other arm is a rhythm control, and that's where, if you go back to our room analogy with the hallways, an antiarrhythmic drug, the whole purpose of that is it changes how the heart beats on a chemical and cellular level to try to quiet down what's happening in these hallways. And so that works in some people, it doesn't in some people, and it's kind of a trial and error that you have to go through with your doctor. The other rhythm control strategy is called a catheter ablation. And so what is a catheter ablation? It's a minimally invasive procedure that is meant to isolate the source of the triggers or these extra beats that are coming in that are causing AFib. And so one of the main ways is called the pulmonary vein isolation. So those hallways that we were talking about before are actually called the pulmonary veins. And those pulmonary veins are the site of the majority of triggers that are causing these extra beats that actually get out and cause AFib. And so how do we do this? There's 2 main methods of doing an AFib ablation. The first one is a radiofrequency ablation, and that's where we use hot energy, and we go in through the veins in the groin, down in the femoral veins, feed catheters up inside the heart. That leads us to the right atrium, which we'll see in just a second. Then we cross over to the left atrium into the room we were talking about, and then we find those veins and then we burn a line around them. The other option is a cryoablation, and that's essentially the same thing. The end result is the same, it's just a different method. It uses cold energy to freeze the tissue. But an AFib ablation is a proven way to help maintain sinus rhythm, particularly in patients that have symptomatic atrial fibrillation. So who benefits from an AFib ablation? Particularly people that are symptomatic, and we talked briefly about those symptoms before, but they include palpitations. Some people just feel like their heart's racing. Some people can feel some flip-flop or fluttering in their chest. Some people have shortness of breath when they have AFib. Some people will have shortness of breath with exertion. That's a big one. And another one is fatigue. Some people just don't feel right. They don't have energy. These are all symptoms of atrial fibrillation that have to be teased out between you and your doctor. So people that are symptomatic with AFib, particularly who fail antiarrhythmic drugs. So those drugs, we're not going to go into all of them right now, but there's a list of a few drugs that we can try that helps quiet down what's happening in those veins to prevent AFib. Some of them have some side effects that some people can't tolerate. And then in addition, once people are on it for a while, sometimes you still continue to have breakthrough episodes of AFib. So those patients particularly will benefit from an AFib ablation. There is a couple of subsets of patients that may benefit from an ablation as a first-line therapy. And one of these is particularly in heart failure patients. So patients that have a weak pump function have been shown to do better with maintaining sinus rhythm with an AFib ablation. The average age of people that have AFib is generally in an elderly population, but every once in a while we get patients that are younger, and so these people may benefit from a catheter ablation earlier, because we don't want to just keep people that are younger on antiarrhythmic drugs their whole life if we can prevent it. So here is a little cartoon of what an AFib ablation is. And so here is your right atrium, and here's your left atrium. And so we go in through the groins that are way down here and feed catheters up inside the heart, and that leads us to the right atrium. And then we use a needle and ultrasound to cross over to the left atrium, where that room is that we were talking about earlier. And so if this is the room, you see these pulmonary veins. These are those hallways in that analogy we were using before. And so we'll play this cartoon. So we go over with a catheter, and then we find where those hallways are coming in, and we burn a line around it, and that disrupts the electrical system. And so it doesn't kill the tissue necessarily, and the blood is still going to flow from the vein, the lungs into the heart. And so that's not going to impede the blood flow as long as we make sure we're outside of the veins when we're burning. But it does disrupt the electrical system, and so that isolates these pulmonary veins, so hence the term pulmonary vein isolation. So here's another example on the other side for the other veins. And so that example was a radiofrequency ablation, so hot energy. And here's an example of what the other method is a cryoablation. And that's where we, instead of using a catheter, we use a balloon, and we put that balloon into the ostium, the entrance to that vein, and freeze that tissue. And so that will destroy the electrical system. And the end goal is still the same. It's going to isolate what's happening in the veins from getting out into the room. So what's a typical post-op course? It's usually an outpatient procedure. So if you have the procedure today, you usually spend one night, and then if everything goes as planned, you go home the next day. Occasionally, depending on the patient and the situation and your doctor, some people can maybe be appropriate to be discharged the same day after their AFib ablation. Typically, the recovery is not too bad. We generally tell people not to lift anything heavy over 5 or 10 pounds for a few days, just to allow some time for those groins to heal where we go into the veins. We do like to note that we like people to stay on blood thinners. So leading up to the AFib ablation, we require people to be on blood thinners to help prevent stroke. And then afterwards, we continue the course of anticoagulation to help prevent stroke. And then when or if you can come off of blood thinners is a discussion you have to have with your individual doctor. We do like to keep people on antiarrhythmic drugs for a few months. So following an ablation, you can imagine if you were to burn yourself on your hand or your arm, there's a lot of edema and swelling that can happen. And so the same thing is true for an AFib ablation and the cardiac tissue. It creates a lot of edema and swelling. And so for the first few months, we like to keep people on drugs, antiarrhythmic drugs, to help maintain a normal rhythm, to allow the heart to, the swelling to go down and the remodeling process to occur. So you also may be put on a couple of other drugs, depending on your doctor, mainly something to help prevent acid reflux from coming up and eroding the esophagus, and then anything that may help with inflammation, such as anti-inflammatories. So what is the complication rate of this procedure? We talked about it's an outpatient procedure, and so generally it's a pretty well tolerated procedure, and it's a safe procedure overall. The field as a whole has done a lot of these. People have a lot of experience with these procedures now. And so the risk of a major complication such as heart attack, stroke, or death is generally less than 1%. And so this is a large study that was done looking at patients at the Cleveland Clinic, data from over 10,000 patients they looked at, and they found complications in 100 patients. And so you can see here, it's typically a pretty low complication rates. And so we'll go through some of these. An effusion is if this is the heart and this is the sac around the heart, the pericardium, sometimes you can poke the catheter through the heart. It's very rare for that to happen. If it does happen, it lets blood leak into the sac around the heart, and that can cause problems. And so if it's bad, we have to put a drain in to allow that blood to escape. If that does not correct the problem, then sometimes we have to call a surgeon that would have to come and open your chest and patch that hole. But again, this is a very, very rare complication that would happen. All of our catheters that we use now have sensors on the end so we can tell how hard we're pushing. And so our technology improvements have really helped cut down on some of these complications. Again, typically we use ultrasound. And so when we're getting access into those veins in the groin, we will use an ultrasound machine that helps us visualize directly those veins when we're putting the needles in so we can tell exactly where we're going. So in summary, atrial fibrillation is a complicated, usually progressive disease. It usually starts off, it's coming and going, and then it starts happening more frequently, and then eventually you're in it all the time, and that's called either persistent atrial fibrillation or chronic atrial fibrillation. And so that's important to note because the treatment success is actually the best if we can get to it in an early stage when you're still what's called paroxysmal. And then a catheter ablation, like we just talked about, has about a 70% success rate. Sometimes we have to go in and touch up those veins again. Sometimes those veins can reconnect. Sometimes you can have triggers that cause AFib coming from outside those pulmonary veins, and we have to go in and find those as well. And so that's pretty much what an AFib ablation entails. And we talked about a major complication is rare, such as heart attack, stroke, or death is less than 1%. So I hope this cleared up some information and was helpful. And now we'll be happy to answer any questions. All right, thank you.
Good afternoon. My name is Dr. Alap Shah, and I'm an electrophysiologist at the Kansas City Heart Rhythm Institute. Today, I will be discussing stroke management in atrial fibrillation, also known as AFib. When it comes to atrial fibrillation, stroke is the most concerning thing from atrial fibrillation. And when you're in atrial fibrillation, the upper chambers of the heart are no longer beating normally. This means that blood can pool, and that pooling blood can form a clot. And a blood clot can then dislodge from the heart and go to the brain and cause a stroke. These blood clots can also go to other areas in the body and cause strokes of your kidney, the arteries to your heart, but the blood clots going to the brain are the most concerning. Strokes are a devastating complication from atrial fibrillation. And if you have atrial fibrillation, you're 5 times more likely to have a stroke than the general population. The strokes from atrial fibrillation are also usually more devastating and more likely to reoccur. Strokes can be prevented, though, if you have atrial fibrillation with the appropriate therapy. And we're going to discuss some of those therapies today. So if you have atrial fibrillation, you may be asking yourself, do you need to take a blood thinner? And the answer really depends on what your CHADS-VAS score is. So as a patient, I think it's very important for you to understand what the CHADS-VAS score is. A CHADS-VAS score is a new scoring system designed to determine your individualized risk for having a stroke with atrial fibrillation. And it looks at several patient characteristics. It looks at whether you have congestive heart failure, hypertension, also known as high blood pressure, your age, whether you have diabetes or not, if you've had a previous stroke, if you have vascular disease. And what that means is, do you have blockages in the arteries in your heart, in your legs, in your neck arteries? And are you a female or not? And depending on what the characteristic is, you may be assigned 1 or 2 points. And then you total those points up. And your total score is your CHADS-VAS score. And depending on what your CHADS-VAS score is, you can find out what your risk for having a stroke is every year. And it ranges anywhere from 1.3% all the way up to 15%. Generally speaking, our guidelines recommend that if you have a CHADS VAS score of 2 if you're a male or 3 if you're a female, blood thinners are recommended to prevent a stroke. When it comes to blood thinners, they're very good at preventing strokes, and you have multiple options. Those can be warfarin or the newer agents called NOACs. Warfarin has been around for over 40 years. It's an effective method at preventing a stroke if you have atrial fibrillation. It's very cost effective. If you have a mechanical heart valve, you can use warfarin because it's been studied very well in that population and is safe to use. Unfortunately, warfarin comes with its share of negative things as well. It interacts with multiple foods as well as other drugs. Warfarin, the dose has to be adjusted, and we want to keep your range within a specific frame. So there's need for frequent testing, and that testing can either be a finger prick or a blood draw. Warfarin also causes increased bleeding in the brain. The alternative to warfarin are newer blood thinners. These are called the novel oral anticoagulants, also known as NOACs. You may have heard of these as Eliquis, Xarelto, Pradaxa, or Cerveza, as some of their trade names are. These medications have been around for over 10 years now. They're known to have less bleeding, have minimal interactions with foods and other medications, and you don't have to take blood tests frequently to determine whether your blood is thin enough. Generally, we will dose the medication based on your patient characteristics, and that dose will sufficiently thin your blood. Initially, when these medications came out, there was no FDA-approved reversal agent. What I mean by that is if you had a life-threatening bleeding complication and you came to the emergency room, early on, there were no medications that we could give you to reverse the action of these blood thinners. That is no longer the case. Many patients feel that they don't want to take these medications because there's not a reversal agent. That's not true anymore. All of these medications have reversal agents. The unfortunate downside to these medications is that because they're newer, they're oftentimes expensive depending on your insurance coverage. When it comes to atrial fibrillation, what we've learned is that most of the blood clots and strokes come from this area in the left upper chamber called the left atrial appendage. This is an outpouching of the left upper chamber, and it has a lot of crypts and crevices within it. And in that area, blood clots can form. And we've learned that over 90% of the blood clots that cause strokes from atrial fibrillation come from this one area. Patients who take blood thinners have significantly reduced strokes from atrial fibrillation, but not everyone can take a blood thinner. Maybe you've had bleeding in the past, whether it be in your upper GI system or whether you've had bleeding from the lower GI system. Some people have had frequent falls or have previously had a significant bleed in their brain. Some people have active lifestyles, and being on a blood thinner just isn't conducive to their active lifestyle. For these people, there are alternatives to being on a blood thinner, which will still allow you to protect yourself against a future stroke. And that's where occlusion of the left atrial appendage comes into play. Currently, the only FDA-approved left atrial appendage occlusion device is Watchman. Watchman is a great option for these patients. And what Watchman is, it's a device that's placed into the opening of the left atrial appendage. And patients who have Watchman also need to be on blood thinners, but those blood thinners can be for a short period of time. And during that short period of time, your own body will grow tissue over the Watchman device to seal off the left atrial appendage. What we've learned through numerous research studies covering thousands and thousands of patients is that people who undergo Watchman successfully The risk of stroke is as low as someone who's on a blood thinner, but you no longer need to take a blood thinner long term. So we've talked about stroke and what your options are to prevent a stroke if you have atrial fibrillation. Now I'd like you to work backwards. There are many patients who have had a stroke and don't have an understanding of why they had that stroke. They've been through numerous tests. They've had ultrasounds of their hearts, ultrasounds of the arteries of their neck, and their doctors are wondering, why did you have this stroke? We label these patients as patients who've had a cryptogenic stroke, which means a stroke of unknown cause. What we've learned is people who have a cryptogenic stroke, their strokes could be coming from atrial fibrillation. As you may have learned earlier in the day, atrial fibrillation can come and go, and many patients who have atrial fibrillation have no symptoms at all. So if you've had a stroke, you should definitely be concerned whether or not you have atrial fibrillation. And if you're one of those patients who has no symptoms, the only thing you can rely on is long-term monitoring of your heart. So discussing with your provider whether a loop recorder is right for you. A loop recorder is a small device that sits on the left side of your chest and monitors your heart 24 hours a day, 7 days a week, and it will automatically detect whether you have atrial fibrillation. And if you have atrial fibrillation, then it would be key for your provider to start blood thinners, because that's the only thing that will prevent future strokes for you. In conclusion, stroke management, in my opinion, is the most important aspect of treating atrial fibrillation. Discuss with your provider which strategy of preventing a stroke is best for you. Thank you for your time.
Welcome to the Global AFIB Alliance Day 2020 discussion on anticoagulation, antiarrhythmics. I'm Dr. Peter Park. We'll be talking about blood thinners and medications that we use in the control of atrial fibrillation. Atrial fibrillation is a leading cause of stroke. Approximately 5 million people in the United States have atrial fibrillation, and this is expected to double by the year 2050. Atrial fibrillation increases the risk of stroke by 5-fold, and 1 in 5 strokes occur in patients with atrial fibrillation. 47% of AFib patients experiencing a stroke will suffer a second stroke within 6 months. Atrial fibrillation causes a disruption of the normal heartbeat. This causes the top chambers of the heart to beat at 300 to 400 beats per minute, which causes blood to swirl and pool in the heart. This can lead to a blood clot that can form predominantly in the left atrial appendage, and if this clot breaks off and goes to the brain, that can cause a stroke. We assess the risk of stroke by using the CHADS-VASc score, and this comprises of a tally of different medical problems, including heart failure, hypertension, diabetes, prior stroke, vascular disease, age, and female gender. And as you can see, as the CHADS-VASc score increases, the risk of stroke also increases up to 15% per year at the highest CHADS-VASc score. Therefore, we have some guidelines that anybody with a CHADS-VASc score greater than 2 requires stroke prevention. And we use blood thinners to try to prevent these blood clots from happening. The predominant blood thinner that we recommend are the newer blood thinners, and we're going to talk about that. But the original blood thinner that we used was warfarin. And this is because warfarin has a proven track record in reducing risk of stroke. This is data going back to 30 years. And these are studies that compared warfarin to placebo. And as you could see, that warfarin in aggregate reduces the risk of stroke in excess of 60%. Unfortunately, there are some disadvantages with warfarin. It is the least expensive drug, and it is still required in patients with mechanical valves or a condition called mitral stenosis. However, the effect of warfarin is dose dependent, and there's what we call a very narrow therapeutic window. We monitor how thin the blood is by measuring an INR, and warfarin is, again, a drug that requires frequent monitoring of the INR. And as you could see, that we try to keep the INR between 2 and 3, because if the INR goes much above 3, there's an increased risk of bleeding in the brain. And if the INR is much less than 2, there's, again, a risk of clots that can form because it's not protective. Warfarin also has multiple drug-drug interactions. And because of these disadvantages, there have been newer blood thinners that have come to market. These blood thinners are Pradaxa, Xarelto, Eliquis, and Zavesa. And you've probably seen ads on TV for these medications. The advantages of these newer medications are that they do not require monitoring. They're easy to dose once or twice a day. There's much, much less drug-drug interactions. And there's stroke prevention, which is equivalent or superior to warfarin. There overall also is an improved safety profile, but these drugs are more expensive. Also of note, for patients taking Xarelto, they have to take it with food because otherwise the medication is not effective. There was a recent trial called the Aristophanes trial that actually looked at 434,000 patients in a retrospective manner, comparing warfarin to the newer drugs, apixaban, dagibatran, rivaroxaban, as well as trying to compare the medications to themselves. What they showed is that in apixaban versus warfarin, dabigatran versus warfarin, and rivaroxaban versus warfarin, all these drugs in a real-world situation improved, were superior to warfarin for reduction of stroke. Also, warfarin and dagibatran had much less lower bleeding. This was not the case with Xarelto. When they compared apixaban to dabigatran and apixaban to rivaroxaban, apixaban seemed to be superior also in terms of risk of stroke as well as risk of bleeding. We're going to change gears a little bit and talk about medications we use to control atrial fibrillation. And key concept in atrial fibrillation is rate control versus rhythm control. In rate control, we try to use medications to keep the heart rate under 100 beats per minute, but we do not try to keep the patient out of atrial fibrillation. In rhythm control, we're trying to maintain sinus rhythm. And there's numerous studies that show that trying to achieve sinus rhythm is probably a superior strategy. These are the medications we use to control the heart rate in atrial fibrillation. These are beta blockers and non-dihydropyridine calcium channel blockers called diltiazem and verapamil. Sometimes we also use a drug called digoxin. And if these efforts are not sufficient, we can use amiodarone. Beta blockers, the main side effect are slow heart rates and fatigue. Sometimes beta blockers can cause diarrhea. Also, calcium channel blockers can sometimes cause slow heart rate and sometimes constipation. Sometimes patients have a condition called tachybrady syndrome where without the medications, the heart rate is too fast, but with the medications, the heart rate is too slow. And if that is the case, sometimes we even have to consider insertion of a pacemaker. This is an algorithm in order to choose an antiarrhythmic strategy to try to maintain normal rhythm. And we stratify patients into patients without structural heart disease or with structural heart disease. And we have a choice of medications that we use in each situation. Flecainide is a medication that we use in patients without structural heart disease. Generally, it is well tolerated, but it has to be used with a beta blocker or diltiazem or verapamil. Propafenone is similar to flecainide. It's taken either twice a day for the extended release or 3 times a day for the short-acting propafenone. Amiodarone is a antiarrhythmic that is one of our most powerful antiarrhythmics. Unfortunately, it can have the potential for toxicities, and it requires close monitoring. It also can cause photosensitivity, so we recommend that you wear a hat in the sun. Moltac is a derivative of amiodarone, and it doesn't have the toxicities, and you don't have to monitor as closely as amiodarone. It's taken twice a day. Sotalol is a drug that also is taken twice a day, and it is an effective drug. However, we have to start it in the hospital. A significant side effect is a slow heart rate that can happen. Ticacin is, again, one of our most efficacious drugs. However, it does require initiation in the hospital. So in conclusion, stroke prevention is one of our primary goals in taking care of patients with atrial fibrillation. Achieving sinus rhythm is an important goal to improving quality of life and improving outcomes. And we have many options to achieve these goals. Thank you very much.
Good afternoon. My name is Rhea Pimentel. I am a cardiac electrophysiologist at the University of Kansas Hospital, and I am delighted today to be part of the Global AFib Awareness Day celebrations. My topic is the treatment of atrial fibrillation, the role of lifestyle modifications. So let's get started. Okay, so atrial fibrillation, as we know, is a global problem. There are 33 million people worldwide with AFib, which is approximately 2% of the world population. About 4 million people in the United States are affected, with the estimated incidence reaching 16 million by 2050. 37% lifetime risk of AFib in patients over the age of 55, and our estimated healthcare costs in the United States by 2050 will be $26 billion. So certainly something that we need to think about. Curiously, North America leads the world in atrial fibrillation incidence, and some of that is because of these lifestyle modifications that we're going to discuss today. These are the 4 pillars of atrial fibrillation management. 3 of them you're probably well aware of: the role of blood thinners or anticoagulation to reduce stroke, the role of rate control to decrease the heart rate in AFib, and then finally rhythm control, which is to keep the patient in regular rhythm rather than atrial fibrillation. We are going to focus on probably the 4th and least known pillar, lifestyle and risk factor management. So these are the risk factors for atrial fibrillation. I've divided them up into traditional and non-traditional risk factors. Some of them we obviously have no control over, such as age or coronary artery disease, but there are several non-traditional risk factors for AFib that we've found can play a role in the incidence as well as the progression of this arrhythmia. So let's start. Weight loss. So weight loss is one of those touchy things that's hard to discuss in a clinic setting, but obviously very important when we talk about preventing atrial fibrillation. There was a study published back in 2015 called the Legacy Trial, where these patients in Australia, there were 355 of them, they all had atrial fibrillation and a body mass index of greater than 27, so overweight, but not necessarily obese. All patients received counseling, diet plans, and exercise, and they were followed for an average of 4 years. After that, they were divided into 3 separate groups based on the amount of weight loss they had and as well as the amount of weight fluctuation. And you can see the results on the right here. The patients who lost more than 10% of their body weight were 46% of them had no atrial fibrillation after 5 years, as opposed to those who only lost 3% of their body weight, 3% weight loss, 13% of them had no atrial fibrillation after 5 years. Additionally, the way that your weight fluctuates also matters. So patients who had a linear weight loss did the best. 76% of patients had a 5-year total freedom from atrial fibrillation, whereas those who actually gained weight, only 38% of them were free of AFib after 5 years. Exercise plays a critical role also in atrial fibrillation as well, treatment options. This is the CardioFit trial. Again, looking at some patients who were overweight but not necessarily obese. This particular trial really focused on what their baseline cardiorespiratory function was, so how fit they were to begin with, and then put all the patients on an exercise program and reassess them later to see how much better they got. And you can see on the left-hand side, the patients who were the most fit, the red line, did the best in terms of freedom from AFib. Probably about 90% were free from AFib. Similarly, the patients who, when they exercised, actually had improvement in their fitness, the red one, greater than or equal to 2 METs, did much better being free from AFib compared to those who did not. When you combined weight loss as well as fitness, again, you see that the red, which is weight loss greater than 10%, and either a gain of greater than or less than 2 METs, greater than 2 METs did the best out of all of them, followed by less than 2 METs, but really the ones that did poorly are the ones that did not lose a lot of weight and did not gain a lot of fitness. There is actually a U-shaped response to exercise. You can see that exercise is good to a point, but once you get to about 12 METs, it starts to be deleterious to your general fitness. And really the recommended level of exercise currently is 150 minutes a week of moderate exercise or 75 minutes a week of vigorous exercise. Obstructive sleep apnea. So sleep apnea is when your tongue falls into the back of your throat and actually closes off your airway while you're sleeping. Patients often snore, and spouses or friends will report that they stop breathing during the night. The early studies show that in sleep apnea patients, 3% of them had atrial fibrillation, which is much higher than the usual population. And then conversely, those with atrial fibrillation were 2.2 times more likely to have sleep apnea. CPAP therapy, which is a mask that you wear at night that provides positive pressure and keeps the airway open, is actually also an effective treatment for atrial fibrillation as well as obstructive sleep apnea. And treating sleep apnea also prevents recurrence of AFib after an ablation procedure. Because we know that patients with severe sleep apnea are more likely to have a stroke, more likely to have cardiovascular death, and die from cancer. They are also at higher risk for developing Alzheimer's disease and mild cognitive impairment down the road. This is a bunch of studies that looked at CPAP therapy in patients with obstructive sleep apnea and how this affected the AFib. And you can see that if you look at all of these studies together, the end result is that CPAP therapy was favorable and had a 44% decrease in atrial fibrillation. Most of the recurrence of AFib in these studies were due to non-compliance with using the CPAP mask. Alcohol is also one of the things that's been looked at recently. We know that alcohol has an effect on atrial fibrillation. There is such a thing called holiday heart syndrome, which is binge drinking that causes atrial fibrillation. There have been actually several observation studies, 2 very large ones that look at the increased risk of AFib in men, just men, who drink more than 35 drinks a week. That's quite a lot of alcohol. But really, any more than 2 drinks a day substantially increases your risk for atrial fibrillation. And we have to manage this with the cardiovascular mortality benefits that alcohol does have. There's been a recent study that's published in the New England Journal of Medicine earlier this year looking at alcohol abstinence for atrial fibrillation. This particular study took 140 patients who drank more than 10 standard drinks a week. They also had a history of AFib, and they divided them up into 2 groups. One was considered the control group, so they did whatever they wanted. And then the second group, they asked to not drink alcohol for 6 months. After 6 months, what they found on the right here is the abstinence group actually had a greater number of patients free from recurrent atrial fibrillation compared to the control. And in fact, that decrease was 53% versus 73% had recurrence of AFib. So quite a significant difference, and really is changing our way of thinking about alcohol and atrial fibrillation. Hypertension is another risk factor for atrial fibrillation. It is a well-known risk factor. If you have hypertension, you are almost 5 times more likely to develop atrial fibrillation. There's been a study called the SPRINT study looking at the effect of being very, very good about lowering blood pressure. So they randomized patients with AFib to either intensive blood pressure control versus standard control, less than 120 millimeters systolic versus less than 140 millimeters. And what they found is that the incidence of atrial fibrillation is significantly decreased the tighter your controlled blood pressure is. Sugar, diabetes mellitus, is the same way. There is a very strong correlation between diabetes and atrial fibrillation. The hemoglobin A1C as well as the fasting glucose levels are independently associated with AFib incidence. So for every 1% increase in hemoglobin A1C, there's an increased risk of AFib by 14%. Moreover, diabetic patients with AFib have more complications compared to those non-diabetic patients with atrial fibrillation. A similar study was done on diabetic control as what we saw with hypertension. The ACCORD trial looked at the impact of intensively controlling sugars on outcomes such as atrial fibrillation. And really what it showed is that if you tried to keep a patient's hemoglobin A1C less than 6, it did not improve morbidity or mortality among the diabetics with new onset AFib. So in this particular case, it is not important to keep the hemoglobin A1C at below a certain level, but to maintain good glycemic control in general. Smoking is another risk factor for atrial fibrillation. This is the ERIC study, which looked at 15,000 people and followed them for about 13 years. They found an association between smoking and atrial fibrillation. The patients who are current smokers compared to those who have previously smoked or never smoked. That's what the graph here on the right shows. The amount of tobacco that you smoke also matters. The more you smoke, the higher your risk of AFib. There was a trend towards lower risk of developing AFib in patients who were prior smokers compared to current smokers. Caffeine has always been something that has been looked at with atrial fibrillation. We all know that caffeine leads to an increase in blood pressure and heart rate. We have to balance this with its antioxidant qualities that is known to decrease inflammation and endothelial dysfunction. Coffee lovers like myself should rejoice because we know that coffee or caffeine decreases the risk of coronary disease and stroke, and the most recent evidence suggests that there is no increase in the risk of atrial fibrillation. This is another meta-analysis looking at a bunch of studies that have been performed in the past, looking at low caffeine use, moderate, and high. And you can see that if you take overall, the little black diamond crosses 1, which basically means that there's no effect of caffeine with atrial fibrillation. In fact, in the low dose caffeine, it was actually protective, meaning the risk of AFib was much less if you had a little bit of caffeine. So a very good news for those of us who like to have our Starbucks coffee in the morning. Finally, I'd like to just briefly review some of these studies on diet and supplements. There was a study called the PREDIMED trial that was published several years ago looking at the effect of a Mediterranean diet and extra virgin olive oil versus nuts and a Mediterranean diet. And what they found is that extra virgin olive oil and a Mediterranean diet significantly decreased the incidence of AFib compared to either control or the Mediterranean diet plus nuts. So if you're ever asked, is there a specific diet? This is it right here. Fish consumption, there is no correlation. Again, a number of studies have looked at this and they're all over the board as to whether fish is helpful in preventing AFib. The answer is probably not. Similarly, the effect of polyunsaturated fatty acids, N3, and we're talking mackerel, we're talking fish oil. Again, probably no correlation between the amount of fish oil you take and atrial fibrillation suppression. So in summary, aggressive risk factor management is an important pillar to treatment of atrial fibrillation and one that I would argue that we should spend more time on. Things like weight loss, exercise, diabetes, sleep apnea, hypertension, smoking, all of these things can be impacted on by the patient themselves to decrease their risk for atrial fibrillation or recurrence of AFib thereof. So in summary, atrial fibrillation is a global epidemic affecting 2% of the world's population. The most recent studies has focused on risk factor modification to suppress AFib and prevent recurrence after ablation. So there is definitely a role for counseling these patients regarding the benefits of weight loss, exercise, smoking cessation, sleep apnea therapy, and alcohol consumption. And really the care of these patients is probably best delivered through a multidisciplinary approach. Thanks for your attention. I'll be happy to take questions during the question and answer session.
So good afternoon. Welcome to the Global Atrial Fibrillation Alliance's YouTube forum on atrial fibrillation awareness education. We had some amazing conversations this afternoon from our local experts here in town. And we went through many important aspects of atrial fibrillation. So, and here is an opportunity to speak with our experts live and have a more moderated discussion here. So I'm going to introduce you to our panelists today, Dr. Peter Park from the Kansas City Heart Rhythm Institute, Dr. Sanjay Gupta from the St. Luke's Mid-America Heart System, Dr. Ria Pimentel from the University of Kansas Health System, and Dr. Scott Kerber from the Kansas City Heart Rhythm Institute. And my name is DJ Lakreddy. I'm from the Kansas City Heart Rhythm Institute as well. So my first question of the day is for Dr. Gupta. So Sanjay, when a patient has a known history of hypertension and hypercholesterolemia and other type of things, at what point should one be worried about developing atrial fibrillation? I mean, in a sense that, like many other primary screening strategies, should we have some kind of a screening strategy that needs to be put in place? And if so, when do we start that? Who do we screen, and how do we screen?
That's a great question. First of all, thank you for putting together this forum, and thanks for inviting me. So we know that the biggest risk factor for atrial fibrillation is just advancing age, and so a lot of our patients who are coming to see us for other cardiac conditions, like you mentioned, hypertension, hyperlipidemia, and they're getting into their 60s, at the very minimum they should get an EKG or an electrocardiogram to check their heart rhythm at each visit. And again, that's something that we should also stress them to get it from their primary care doctor. Since we know the majority of patients with AFib are asymptomatic, this is an important screening tool. I think that and it's important to take a history as well for symptoms, and it's just important to bear in mind that symptoms for AFib can be nonspecific. The most common symptom is just fatigue. And so asking patients simple things like, are you able to do the same things that you did a year ago? And or do you find yourself running out of steam? I think those are important things to try to help tease out what may be histories of AFib.
All right, and so I mean, imagine if somebody wants to get proactive on this. I mean, like you now have the blood pressure cuffs available over the counter. You can buy a glucometer, especially if you have a strong family history of diabetes and stuff, that you are able to check your blood glucose on the home front. So, Dr. Pimentel, what do you think is the best method to monitor oneself, like a patient who wants to be proactive about these type of things, and maybe perhaps they have a remote family history of atrial fibrillation, parents with known AFib, and they have a few risk factors that we have outlined in our conversation earlier. What would be the best way that you suggest for our patients to screen themselves from time to time from home?
Well, that's a great question, DJ. And I think that's, fortunately for us in this day and age, we have a lot of mechanisms to do that. My talk obviously discuss some of the factors that we could affect, like good blood pressure control, good diabetes control, and all of those things can be achieved with your primary care provider. But from a standpoint of, do you know when you're having AFib? We have a bunch of wearables out there that are now available. There's the eCardio device, which is the device that you place in the back of your iPhone, where you can actually record a single lead tracing of your heart rhythm, which is a wonderful tool for patients who maybe don't realize that they're having that may feel something but don't know if it's atrial fibrillation or not. It can give a lot of feedback to the patient. If it is positive, there's something abnormal that can easily be sent to their primary cardiologist or electrophysiologist, and then they can go from there. Otherwise, other things such as implantable loop recorders can also be utilized for patients who may have asymptomatic rhythm issues, and that would be done in conjunction with your cardiologist.
So this particular technology that you talked about, the eCardio or the Cardio Mobile or any number of the smart AF tools, I mean, how easy are they in terms of cross-verification instantaneously versus do they have to be sent to their cardiologist to be interpreted, or do these things right away tell you whether you're in AFib or not?
I don't think that they will tell you for sure that you're in atrial fibrillation. Of course, everything should probably be run through a trained professional who reads these EKGs. I do know because I have invested in an Apple 5 watch, so this also has the same sort of technology where you can record a single tracing EKG, and it does give you everything's fine, or possibly atrial fibrillation, or call your doctor response to it. So I think it'll give you an idea. Of course, again, the bottom line is it still probably should be evaluated by your cardiologist before we say for sure that you don't have atrial fibrillation.
I see. So Dr. Kerber, coming to the same issue of family history, I mean, of course, family history, as we know, in cardiovascular medicine is an important risk factor. And if somebody does have atrial fibrillation in their parents or siblings and other things, what would be a best approach in terms of, is there a genetic test that one can do to confirm whether they have the gene to develop atrial fibrillation going forward, so that they can take all the necessary precautions and be overtly more cautious than an average person would be? So if so, are these genetic tests, how reliable are they? Are they currently available in the market space? And should the patients be talking to their doctors about having these genetic tests done?
So, I mean, that's a great question. We face this a lot in clinic. Patients come in and they don't necessarily have symptoms themselves, but they do have family members that have symptoms or have been diagnosed with AFib. And I don't think we know all there is to know about the genetic component to atrial fibrillation. I think that there is certainly, some risk, particularly in first degree relatives if you have it. But I still think that I tell people to go based off of symptoms. I'd throw this question out to other people who may be more apt to using tests, genetic testing. I don't personally use genetic testing.
I don't use genetic testing either. As part of my routine clinical practice.
Okay. The only subset would be in probands of HOCM, because there's a high incidence of AFib and hypertrophic obstructive cardiomyopathy. And so, first degree relatives, if there is that history, they should be screened for that. But I mean, I think there's been some probands like in Chinese populations that have identified genetic predisposition, but I don't think there is a test right now for the market specifically for AFib.
I wasn't aware of one either. I didn't know if you guys knew something I didn't.
So it's suffice to say the genetics of atrial fibrillation are yet to be well defined, and there is no readily available test other than what has been shown in research purposes. So clinically, for regular day-to-day use in the clinical setting, we may not have a test yet, but maybe who knows, in the next 10 years we may find more about this. Excellent. So in terms of general risk screening and other things. I mean, there's been a lot of conversation about the role of obesity and sleep apnea and alcohol use and many other risk factors that go into the mix. So in your clinical practice, Dr. Park, do you routinely utilize the sleep apnea screening, and what exactly do you do when somebody comes in with atrial fibrillation and you're going through your routine questionnaire on many other risk factors? Tell us more about how you screen your patients for sleep apnea and what do you do and why is it important in the management of atrial fibrillation?
Well, I think as Dr. Pimentel discussed in her discussion, sleep apnea has a very strong association with dysrhythmias, including atrial fibrillation. So in my practice, I keep a high index of suspicion for sleep apnea in all these patients. And one of the things that we all have to be careful of is that stereotypically, even thin people can have sleep apnea. So typically the questions I ask is if they know that if they've been told that they snore, if they wake up feeling tired, and if they're having daytime sleepiness. And depending on how high my index of suspicion, I might just screen them with an overnight sleep study that they can do at home or versus having a formal sleep study. So these at-home diagnostic sleep studies have made it a lot more convenient to screen larger number of patients. But I think it's sort of a tip of the iceberg kind of thing where we don't fully appreciate how much sleep apnea there is out there.
Excellent. So there are certain scenarios where patients do find it hard to wear these positive airway pressure machines. They blow on their face, it makes their nose dry, and a lot of times, I mean, it's just a sheer inconvenience that affects people's overall quality of sleep. And after they try for a while, I mean, some patients obviously give up, and I mean, they're trying their level best to lose weight and their neck girth and whole 9 yards of that. In scenarios where somebody cannot tolerate a CPAP or a BiPAP machine, are there any other special opportunities to help their sleep apnea? Dr. Gupta, this question is for you. What kind of therapies or strategies are out there when somebody cannot be on a CPAP machine?
You're
Unmute.
muted.
You have to
So you
unmute.
have to unmute.
Just kidding. Okay. So, sorry, there's about 3 or 4 different alternatives that can be considered to CPAP for select patients. So some people have a real anatomic obstruction in the back of their throat. And so part of the back of the throat can actually be removed. So the little uvula, the little thing that hangs in the back of the throat, that can be removed as part of some tissue back there. And that's one. Some people are surgical candidates for that, and that's one way to do it. Some people have a tendency for the jaw to fall back and obstruct the airway. And in those people, a dental appliance can be used that pulls the jaw forward, and that can then open up the airway there too. The only problem that I find with that in routine practice is that it's very expensive, and most dentists don't routinely test their patients after they have it done. So if you're a patient considering having that done and you have it done, make sure you also get a sleep study afterwards to make sure that your sleep apnea is treated, because don't just assume that the dental appliance worked. And a third thing that's come out in recent years that's been really interesting is a technology based upon pacemakers, where instead of wires that are placed that go down and that stimulate the heart, it's a little device that goes in the left upper chest, and it stimulates the muscle that is on the base of the tongue. And by stimulating that, it can actually lift the tongue off the back of the throat, and it's just at a low level that the person doesn't wake up, but it's enough to relieve the obstruction and open the airway. And for some people, this has really been a lifesaver. I've had a few patients that have undergone this, and this is after they had failed everything, and it's been quite revolutionary. And the neat thing about it, they just sleep like normal people do. They don't have to put the mask on, and they do, and they just turn this device on before they go to bed at night, and then they sleep, and they breathe normally. It is a difficult procedure to qualify. In fact, all of these are. There are only very few people who are candidates for them. But in particular, that device, which is called the Inspire device, you have to be this unusual combination of having at least moderate to severe sleep apnea, but also being relatively thin. And so in my experience, the two people that have qualified for it were women. And so they're typically pretty thin women in their late 70s, who had very severe sleep apnea, sort of surprisingly severe. One woman had failed 5 sleep studies, but was able to get relief finally with this device. So I do think it's important to look at that. But I would say one last thing is that the technology itself for the sleep apnea for the CPAP devices has improved tremendously. And a lot of people who may have tried it years ago and got frustrated and gave up because they couldn't do it, I would urge them to go back and try again. The newest masks are much better. My favorite is something called nasal pillows. It just goes just in the nostril and wraps around the ears. There's nothing over this, and it's not as claustrophobic. It's much more comfortable, and people have been able to tolerate that who couldn't tolerate anything else. There is about a several month period when you first start wearing CPAP where you have to get used to it, and then eventually, if you push through that and you stick with it, eventually people find that they can't sleep without it.
Right. I mean, that's a pretty useful tip. So let's switch our discussion a little bit to alcohol. I mean, this is the drink of the gods, and everybody enjoys a glass of alcohol here and there. And so there's a lot of debate about what's good for plumbing may not be as good for the electrical system of the heart. And this question oftentimes comes up. The booze paradox is what we call it. So, Dr. Park, this question is for you. And so how much alcohol is too much when somebody is at high risk for atrial fibrillation or somebody already has atrial fibrillation? And why is it so? I mean, because a glass of red wine seems to be an important factor that helps to keep heart disease away. That's what my general cardiologist told me. And then now I go to an electrophysiologist, and the EP doc tells me stop drinking. So what's up with that?
Well, I hate to be a buzzkill, but unfortunately for some people, any amount of alcohol might be a trigger. So I think it is really patient by patient basis. My concern when I counsel patients is that, sometimes one glass leads to 2, leads to 4, and probably a glass of wine or equivalent per day is probably going to be okay for most people. But clearly there is association with binge drinking and initiation of AFib. And again, for some people that are that sensitive, they may have to be completely abstinent. Bummer, but yes.
So Dr. Pimenta, would you ever allow your patients, after you say fix them with the help of medicine or with the catheter ablation, would you allow them to have a glass of wine every day, or what's your routine recommendation to your patients on that?
Well, my recommendations have changed a little bit since the most recent studies that have come out looking at abstinence and the improvement in freedom from atrial fibrillation with just not drinking anything at all. I push back a little bit on that because I think if we're too firm about that, I think we will end up with patients who just don't do anything and they just keep drinking what they're drinking. If you look back at some of the old observational studies, Framingham, the Danish diet study, Copenhagen City, and then actually the Nurses' Health study, you see that really women do a lot better. So some of those studies showed that women actually did not have an adverse atrial fibrillation. Being female did not, with being female, your AFib burden did not increase with alcohol use as opposed to males. So I personally do what Dr. Park does. I tell him, one drink is fine. I'm not going to tell you can't ever have something ever again. Understand that the more you drink, the higher your risk is of having recurrent atrial fibrillation. I'm a little bit more lenient with the women as opposed to the men, but certainly one drink would be my limit for them.
All right. Thank you. That's very helpful. So we'll now switch gears a little bit to another drug, recreational drug that is becoming increasingly popular, and that has really changed its position from being a real drug to it's acceptable kind of a deal, where the marijuana rules across the world and across the United States have changed, and many states have legalized it, and there is an increased consumption of marijuana the mean consumption is significantly gone up in the United States. There are many patients that come up and ask you about, is it okay to smoke a joint here and there if it is legal in their respective states? What's the data behind it? I mean, there is medical marijuana that says that, yeah, you can smoke marijuana if you have back pain or if you have many other disorders, and now you have a plethora of marijuana or CBD oil-related products that are coming out and that are claiming gains in health improvements and stuff like that. So, Dr. Carter, what's your take on effects of marijuana and atrial fibrillation, and is there something that people should be worried about? How does it all play into this AFib business?
So I actually just take it, it's kind of like Dr. Park does, on a patient by patient basis. You know, I mean, there is some evidence show that there may be some association. I'm not sure that it's every patient. And so some patients just have triggers, some being alcohol, some being marijuana, some being caffeinated beverages. So I just kind of assess every patient individually and see if they can identify what triggers are actually causing their AFib. And if that's identified as a trigger, you know, it's a repetitive thing every time they, use marijuana, then they go into AFib, then I certainly tell them, once we identify it as a trigger, to cut back. But I'm not sure that every patient fits into the same mold. What do you guys think?
Yeah, I would agree. I mean, I like your approach in sort of engaging the patient in their own care, and I do the same approach. I mean, I try to both alcohol and those, but I take the same approach as you do, and I think that that's very powerful, and it gets them engaged as well.
I feel like I try to be cautious on the initial consultation when people are coming in and we're evaluating for AFib. I mean, if we tell them that they really can't do anything, they can't have caffeinated beverages, they can't drink wine, I feel like if we're too hard on them and we restrict so much that we're actually going to lose more patients that way, and they're going to say, well, I can't do it all, so I'm just not going to do anything. So I kind of take it step by step.
Right, so you kind of use a graded approach to get their lifestyle modification in order to get to the endpoints that you really want to get to. There are a lot of questions that come about impact of exercise and atrial fibrillation. I mean, we all know that exercise is good for your heart, and I mean, 30 minutes of exercise 3 times a week keeps your doctor away. And then on one hand, I mean, we have this whole spectrum of increasing obesity across the globe, and then you also have a spectrum of people that are increasingly health conscious, that work too hard, and there are marathoners, and I mean, there's a lot of chatter about too much exercise is real too much, and too little exercise is also bad for you from an arrhythmia standpoint. Can this thing be real? Like there is something called too much exercise can cause AFib, and too less exercise can cause AFib, and what's the sweet spot? So Dr. Pimentel, can you tell us more about this exercise paradox on atrial fibrillation?
Well, I think there truly is something out there where you can exercise too much and cause atrial fibrillation. I mean, there are some studies out there that have looked at it. They look at the thought that maybe 12 METs, metabolic equivalents, and you would have to kind of calculate that based on your own body mass and such, how much exercise that would be. But that would be kind of the limit as to when it starts to actually hurt your heart and increase your risk of AFib. We know that AFib can be triggered by things like dehydration, which goes along with excessive exercise and such. So I do think that there is something out there with this exercise paradox, and it makes sense, right? Everything else is like that too. If you do too much of one thing, it can be harmful to you. You know, in fact, when I tell my patients this, most of them actually breathe a sigh of relief, because then they realize that there is an upper limit for where they don't have to do more than that. So, but I do think that there is some data to suggest that there is an exercise paradox out there.
Very good. So we can now switch a little bit to different type of treatment options that are available and how it really plays out into the mix. So when a patient goes to a doctor and seeks help for their atrial fibrillation, I mean, obviously there is a conversation about the blood thinners and aspirin and rhythm drugs and all of that. So, I mean, the data seems to be quite clear that the so-called novel oral anticoagulants, or the new generation blood thinners, are definitely doing better than warfarin, and we see that reflected by its use. More than 80% of all blood thinners that are prescribed in the last 5 years seem to be the novel agents, and warfarin is really losing ground on that front. So if I'm the patient and the doctor is telling me that I need to get on a blood thinner, how should my doctor choose, or how should I choose what kind of a blood thinner that I should get on? Maybe this question, Dr. Gupta?
Sure, it's a good question. And I agree. It's been interesting to see from when I was in my last year of fellowship. You know, we had the first of the novel agents, and now we're just starting to see the tide change. And it's now come full swing. Now we have 4 good agents. I think the data for all of them is they're in terms of efficacy, they've all been compared in single comparison. Each one of them is compared to warfarin, and they've all been shown to be superior to warfarin or Coumadin in terms of their ability to prevent stroke, and many of them have been shown to also have at least the same or decreased risk of bleeding. So I think in terms of clinical efficacy, I think they're roughly pretty equivalent, and I don't know that that if there's such a huge difference between one or the other that that it would warrant a difference in the price. And I feel like that ultimately, unfortunately, is the biggest determinant in my practice is what is the preferred agent on the patient's formulary. A lot of times I will pick an agent, and then the patient will go to their pharmacy, and then they'll find out that it's $400, and they say, I can't afford that, and yet another essentially equivalent agent is like $40, and so a lot of times it ends up coming down to finding an agent that is a preferred agent that the patient can afford. Other factors that I think are important to consider: 2 of the medicines are given twice a day, whereas 2 of the medicines are given once a day. So for people who have difficulty remembering taking medications more than once a day, a once-a-day medication may be an advantage. One of the medicines, Xarelto, does need to be taken with food, and typically they have you take it with one of the largest meals, so it's typically given at dinner time, which is a little bit unusual time. Not many patients take their medicines at dinner, but if they can do it, again, it's great to be able to take an agent once a day. If patients are already taking something twice a day, some of the heart rhythm medicines we give them, it's not a big deal to put them on something they take twice a day because they're already sort of in that routine. But beyond that, I do feel I tend to use all 4 of them, and I use them fairly interchangeably, and I've had good success with all of them.
So, I mean, a lot of patients nowadays are on blood thinners, and then you come across when these patients go visit with other physicians and they needed different kinds of procedures like a colonoscopy or an endoscopy or a biopsy of some sorts for the prostate, they get told to stop these blood thinners. And so, I mean, we know that the effects of warfarin last much longer, whereas these blood thinners wash out relatively quickly. So if somebody misses a dose or 2 of their blood thinners, I mean, how worried should they be? And how do you really get back into the rhythm again without really losing much ground from a stroke risk. Dr. Park, you want to take that question?
Well, with respect to paraprocedural, stopping blood thinners, my usual practice is to stop, the newer agents within 2 to 3 days. We've learned a lot about this whole concept of bridging somebody with Lovenox, and we've come to realize that that's really not necessary and probably increases risk of bleeding. So I think if they, if they hold their blood thinner for a few days before and then resume as soon as it's safe from a surgical standpoint, I think that's acceptable. In general, I think just because these agents have such a quicker onset of action, if they miss 1 or 2 days, I think it's okay. Now, when it comes to doing, let's say, an atrial fibrillation ablation, I probably would still be a little bit concerned about a possibility of a thrombus if they are in persistent AFib pre-procedure. And that has some implications on whether we would image them before procedure.
There's a lot of debate about atrial fibrillation management, and we clearly see a dichotomy in some of the older practitioners versus the current generation practitioners. There is this thing about rate control and rhythm control, and there's a lot of debate about whether just taking a beta blocker and a blood thinner is good enough, or should we really push for getting back into normal sinus rhythm. I think there is a progressive change in the information that's available and what we have learned over the last 2 decades. So what are the questions that one should ask when a patient goes to seek help, and for the first time somebody presents an atrial fibrillation and they're seeing their doctor and the doctor tells them XYZ? How should the patient know that what he or she has been told is appropriate for her, and what questions should they be asking about rhythm control versus rate control? How should they educate themselves on this particular issue? Ria.
I think we all encounter this patient a lot in our own clinical practices. You're right, there are many people out there that favor rate control or just patients staying in atrial fibrillation with a controlled heart rate rather than truly getting back into sinus rhythm. I happen to be one of those people who really favor trying to get patients back into regular rhythm. And so when I see these patients, I ask them a whole lot of questions. I think history is key here. The questions of, do you think that there's anything different? Do you feel any different? Could you do all the things that you were able to do 6 months ago or a year ago? Those kind of things. Because I think a lot of times we adjust what we do based on what we can do. So the patient themselves may not feel like they're limited, but they are limited, and they don't realize it until after we've gotten them back in regular rhythm. So my usual conversation with the patient is, even if they are truly asymptomatic, meaning that they don't complain of any change in their symptoms in the last year or since they've been diagnosed with AFib, I always try and suggest that we still get them into regular rhythm at least once, just to kind of see, because I have equal amounts of time have had patients come back and say, oh my gosh, I didn't realize I was as down as I was. I have so much energy now and I never realized it. And then I have another subset of patients who say, I feel exactly the same in regular rhythm. At least in that standpoint, then I can clearly say to myself, okay, this person truly does not feel their AFib. Once we talk about that, then, we have to also review some of the data that's looked at the effect of AFib on mortality and hospitalizations and such. So even if you are asymptomatic in AFib, there still is an increased risk of dying just by virtue of having atrial fibrillation. And all those discussions have to happen to the patient. I think it's a patient-to-patient conversation, because some of them really do just as well in regular rhythm as they do in AFib. And then others, you get them back into sinus rhythm and they say, oh my gosh, I'm so glad that we tried this, because I couldn't imagine living the way I did, now knowing what I have in regular rhythm.
On that note, there seems to be a lot of buzz about the rhythm control strategy versus rate control strategy from a large trial that recently came from Europe. And there was a lot of newspaper and press coverage about it, and that the old thought process may not be as good. So Dr. Gupta, you want to throw more light on what was found and how that is relevant to the conversation right now?
Yeah, and I think this is really interesting, the East AFNet study that just came out of, I think it was from Germany, and it was very interesting that they found that patients who were diagnosed earlier in the course of their illness, so patients with relatively recent onset fibrillation, a little bit younger, who then took more of a rhythm control strategy by undergoing catheter ablation, were not only did they do better from the standpoint that they were better able to maintain rhythm, they had more favorable outcome from the procedure. But actually, this is the first study really showing sort of a significant decreased risk of mortality. So they were less likely to die with this, which has been really noteworthy. A lot of the studies before that have been done, very large, very well done studies before this, have shown that having an ablation does help does help you feel better. It helps you improve your quality of life. But in terms of showing kind of a significant decrease in risk of dying, that's only one other study before this has been shown in patients who had an implantable defibrillator, where it's a very select patient population. So this is interesting. So this I think what my take home from this, I think a lot of this is like any progressive disease, any disease that gets worse over time, whether it's diabetes or hypertension or kidney disease, whatever it is, the earlier you intervene with sort of the most important life-saving therapy, the better outcome it is, and the easier it is to treat the disease, and the better the outcome is for the patient long term. And I think that's what is really sort of the take-home message from here. And I think that the onus is now on us, kind of getting back to how you started this discussion, DJ, is that because so many patients who have AFib are asymptomatic, we have to find them in their early stages. And that was really important for us as a society, as a field, as a profession, to get better at getting out there and finding those patients early on and identifying them when they're at the early stages, because that's when I think studies like this show, when we intervene then, that's when we really save lives. When they come to us after 2 decades of AFib and they've got, enlarged heart and all of the heart problems, it's too late. It's very much more difficult, and a lot of the damage has been done. So I think this is hopefully, I think, going to be a sea change in the way we approach this disease.
Dr. Park, this question is for you. There's a lot of discussion about worsening premature dementia in patients with atrial fibrillation, and new material that's coming out to show that perhaps leaving people in atrial fibrillation may dramatically worsen this, and that reversal of atrial fibrillation could actually help reverse some of the brain changes that people have undergone over a period of time. I mean, can you tell our audience more about what this whole dementia phenomena is about, and how does this really fit together?
I think, as it's been said before, that AFib is a progressive disease, and it's always better to catch it in a proximal stage versus permanent or persistent stage. And it's probably twofold, because there's probably an issue of cerebral hypoperfusion. Hemodynamically, when you're in atrial fibrillation, you have a loss of at least 20 to 30% of your cardiac output. And then there's also the concern of silent strokes and cerebral ischemia, which probably goes hand in hand with that. So, I agree that I'm of the opinion that we should try to stop AFib earlier than later.
So this question is for Dr. Kerber. There are many times, many young people that see you for their atrial fibrillation are placed on amiodarone for a long period of time. I mean, I think it's almost, in a very simplistic way, you go to your doctor, they put you on a blood thinner, then they give you a prescription for amiodarone, and then you're taking it forever. So there is enough literature that's out there that amiodarone is a pretty nasty drug in terms of systemic side effects and so on and so forth. So when should a patient worry about being on amiodarone? How long is too long to be on it? And what kind of surveillance need to happen? Or is it your opinion that one should do their level best to get people off of amiodarone if they can?
So that's a great question. I think that it's very common that we see people, for other reasons, device management and things like that, I've noticed they've been on amiodarone for years and years, and people in their 40s and 50s, it's like you said, there's a lot of toxicity, particularly that builds up over time. So I usually worry about it more in a long-term setting. I think that it is, on the other hand, a very effective drug. So I actually use amiodarone quite a bit, but I always have to have an exit strategy with it. So when a young person comes in and they are not on any antiarrhythmic drugs, and we talk about ablation, if once people decide they want to do an ablation, I actually use a decent amount of amiodarone just for about a 3-month period following ablation. But on the other hand, when patients come in and they don't want to try an ablation, I tend not to select amiodarone unless it's in an elderly population, particularly just because what you talked about, the side effects that can affect the lungs, the eyes, the skin, the liver, the thyroid. So there's a lot of routine labs that if you are going to be on amiodarone long-term that we need to follow, with chest x-rays and then yearly labs looking at certain organs that have been affected by amiodarone in the past. But I tend to use amiodarone in selected patients, particularly if it's going to be destination therapy where we're just going to keep them on amiodarone in elderly patients, and then try to steer away from that in younger patients.
So the question of catheter ablation comes in often, and there is a bit of a debate about when is the right time to consider somebody for a catheter ablation. I mean, obviously, if somebody had failed multiple antiarrhythmic drugs and they're very symptomatic, that's not being able to be controlled, you talk about proceeding forwards with a catheter ablation. What is the right timing to consider catheter ablation? I mean, somebody that comes and sees you in consultation, I'm going to ask each one of you how and when you offer catheter ablation in your practices. And so maybe let's start with Sanjay, and then we go on to Ria and Scott and Paul and Peter.
Great. Yeah. So I think typically when I first see a patient and I come do the initial visit, my plan is to try to look and assess for any sort of reversible or modifiable risk factors and try to aggressively treat those even before we people may come for an ablation, but I tell them, look, this procedure itself is not magic. Just doing this alone is not going to suddenly just cure you of AFib if we don't address all these other risk factors first. So I typically start with that too. And then I give them an option of trying a medication just to see if they want to see how they do on that. But some people are interested in trying that, and some people just want to go directly to an ablation. I think for younger people who don't have a lot of other medical problems, who are very interested in getting good control of their AFib, I do think it is reasonable for some people to proceed directly to an ablation, and I will often do that. Typically, though, I do have them still take an antiarrhythmic medication for purposes of kind of, as Dr. Kerber said, kind of getting them to the ablation and then help them through their recovery afterwards there too. But for the majority of my practice, I will say typically it's patients who have had who have been tried on an antiarrhythmic and then either had side effects that were intolerable or had breakthrough AFib. And for those, I would say that's the most common patient that I take for ablation. Typically, the course is the patients that I meet in their 60s, start them on a medication. By the time they get to their 70s, it's progressed to the point where they're having breakthrough or side effects, and I do most of my ablations between age 70 and 80.
So I think my patient population is probably similar to Sanjay's. Most of the patients that come to see me have already been tried on an antiarrhythmic drug and they already know what they want. But on the rare occasion, I have a patient who comes as, somebody who's not tried anything. I bring up ablation right at the beginning, and sometimes I bring that up just so that they have an idea that there's something out there other than just medications. And it gives them sort of a feeling that they're a lot of these people come and they just don't know what to expect. At least they feel like there's some hope that there's lots of different options out there. We talk about risk factor modification also, particularly looking at things like sleep apnea, weight loss and such. I do feel like if I have a patient who has either signs of LV dysfunction, probably tachycardia mediated, I am much more aggressive at trying to get them in for an ablation rather than trying to sit on them and try an antiarrhythmic drug, and then seeing how things go with that, particularly if they're asymptomatic with their atrial arrhythmias and also have tachycardia-induced cardiomyopathy. I think that's kind of a low heart function and AFib that they don't feel. I think that's kind of a bad combination because they can't really tell me what's going on or how their antiarrhythmic drug is doing until they're back in AFib and their heart function is down again. So those are the patients that I tend to be pretty aggressive with in offering ablation sooner rather than later.
Right.
Yeah, I kind of have the same practice style as the previous two. I think at the initial consultation, I do like to look for reversible causes. I always get an echo on people if they don't have one, just so I know, like Rhea was just saying, if they have heart failure, I am going to be more aggressive and rhythm control with an ablation first. But typically, I think the majority of patients that you get from a general cardiologist nowadays have been tried on multiple antiarrhythmic drugs. Sometimes they failed a couple cardioversions. And so at that point, that patient's a little bit different because they've already been tried on all that. So then the next step is just logically going to be an ablation. But I do try to get aggressive, like Rhea said, on certain subsets of patients, particularly younger patients that really don't want to be on medications the rest of their life if there's a chance we can get them off.
Yeah, I would agree with everybody. Drug refractory atrial fibrillation is a class 1 indication for ablations, and that's the majority of our patients that they've already been tried on medications and they failed in one way or the other. Heart failure is also a real significant target of that we should be aggressive on in offering AFib to restore sinus rhythm. And the young people, it's interesting, right? Because sometimes people really truly have AFib by P-vein etiology. However, I've seen people who've had accessory pathways and AV-NRT and just SVTs that are the initial drivers for AFib. So that's also an opportunity to take care of those arrhythmias at the same time.
Thank you. I think it's quite clear that radiofrequency ablation as a definitive therapy is becoming increasingly more widely available. I think there are more operators around the country to be able to offer more effective therapies than what it was about 10 or 15 years ago. And you do come across scenarios where AFib ablation can be used as a first-line therapy in the appropriate patient population. So I think we've made some incredible advances in the technology, and the procedural complications have come down. So I think in the right hands, at the right institutions, at the right programs, radiofrequency ablation, I think could be a very important cornerstone therapy for atrial fibrillation. So we'll switch gear a little bit about stroke prevention and stroke management in AFib. So there are a lot of advertisements that are coming on television and radio and internet about this appendage closure device. And for a patient who has never heard about this appendage, what exactly is this left atrial appendage? Are there any similarities between this and the appendix that we hear about in other parts of the body? And why is this appendage all of a sudden gotten so much notoriety? Dr. Gupta?
That's a great question, and I love your analogy of the appendix of the intestine. I use that all the time. So what's interesting, so the left atrial appendage is just a little outpouching of the top parts of the heart. And what's interesting, from when it's a remnant of when we were all in our mother's womb and we were developing, that actually was the heart in its earliest stages of development. And then as the whole rest of the heart grew out of it, it's left behind as a remnant and has no function in the adult person. It does cause trouble, much like the appendix of the intestine does, and frequently, when someone's frequently having like open heart surgery, the surgeon may just choose to remove it because it has no useful function. Not really has much. It does secrete a little bit of a hormone and can take on some blood, but typically it has no useful function. But it is where, when someone is in atrial fibrillation, that is the part of the heart where the blood is moving the slowest, and that pooling blood there tends to clot, and that's really where the majority, if not all, the clots form when somebody has atrial fibrillation. And so the strategy that was, when the first studies were done years ago, sort of that proved this, was the fact that by sealing that off or occluding that appendage, they were able to get the same protection from having a stroke that people got who had been on blood thinners. And that was, I think, sort of proved this hypothesis that we'd had for years, that the appendage is really the source of all of these strokes. And so now there are several devices out there. I think the Watchman is still the most common, and that are useful to sort of seal this part of the heart from the inside. Once it's sealed, sort of like a cork in a wine bottle, no blood can get in or out of that, and the body will go tissue over it, and it's just as if that part of the heart never sort of existed. But it does, in select patients, give them a chance to get a decrease in the risk of having stroke without having to take on a risk of bleeding. And for many patients, they have a long-term risk of a stroke, but a very short-term risk of bleeding, such that they really are not a candidate for blood thinners. And for them, this is a great option.
Thank you. Dr. Pimentel, when somebody gets this kind of the so-called appendage closure device, when do you feel comfortable getting them off of the blood thinners? And are there scenarios where you consider keeping them on long-term blood thinners versus taking them off?
Yes, I think there are some protocols in our institution that we use. Obviously it's very important to make sure that this occlusion device, this sealer, so to speak, actually did the job and is starting to heal up. So a lot of times we'll do a transesophageal echo or a special ultrasound to kind of look at that area to make sure that it is still sealed, that area, and there's no blood flow that goes into that appendage. If that looks good, that's typically occurs at about 6 weeks or so, then I feel pretty comfortable taking the patient off of blood thinners. Until then, they're on blood thinners plus another agent called Plavix, which is a more of an antiplatelet agent, so to speak. And then I would keep them on that second medication, that Plavix medication, for a few more months to make sure that everything's fine. But that's typically what my protocol is. I have had a couple patients stay on anticoagulation despite having a good seal of their appendage, and those are patients who have had maybe other indications for blood thinners. Obviously, so if they've had blood clots in their legs that could go to their lungs, that would be a patient that would not be, they would get no benefit from closing off that left atrial appendage because the mechanism is a little bit different, so they still need to be on blood thinners.
Right. Dr. Corbett, in your practice, who is an ideal candidate for an appendage closure? And who do you offer this to? Or do you think this is something that we've got to put in everybody that has atrial fibrillation so that we can take them off of blood thinners?
So that second part is a very interesting topic. I think, certainly we need some cost-effective analysis to be done on, is it appropriate for everybody? But particularly people that have, had major bleeding, so GI bleeds, particularly people that are on dual antiplatelet therapy, they just had a stent put in, they're also on AFIB. People that have multiple instances of GI bleeds, intracranial bleeds, so any just major bleeding issues that they've had, I tend to be more aggressive in offering these type of devices, just try to prevent them from being on blood thinners longer. One interesting question that I've seen from a lot of patients, I was going to ask you, DJ, to address is it's becoming a trend in cardiac surgeries where people just exclude the appendage, whether it be a clip or surgically excised. Most of the studies that we have for Watchman have been in people that can't tolerate anticoagulation. And so what do you tell your patients when they come to you and they've had a surgical, an open heart surgery for, CABG or, bypass or valve, and they happen to just exclude the appendage while they're there? What do you tell those patients about blood thinners?
It's a good question. I mean, I think when you really look at the site or location of clot inside the heart, I mean, we know that more than 94% of the clots come from the left atrial appendage. But there are the other group of patients that may have septal pouches that could harbor these clots. Sometimes they can adhere to the posterior wall, the valves, and things like that. But the vast majority of the clots do come from the left atrial appendage. And then the next question you have to ask is, even after the left atrial appendage is eliminated, a lot of times that appendage elimination may be incomplete, right? So your clip may not be positioned appropriately. So a very large segment of the appendage may still be intact with significant trabeculations. And in those particular cases, I mean, we have seen case after case where there are clots even after somebody has tried to eliminate it. So in cases where the appendage has been successfully eliminated, when they have successfully excised and oversewn it, or the clip has been deployed very nicely, where the stump is less than a centimeter, the risk is significantly lower. So in these cases, it doesn't mean that I'm just gonna let them be in atrial fibrillation and take them off of blood thinners. My goal is still to get them back into sinus rhythm, irrespective of their appendage is eliminated or not. And as a result of which, I think we provide a more comprehensive rhythm restoration, and also atrial function can be restored a lot better. So the overall risk of non-LAA type of clots and subsequent thromboembolic events would significantly be lower. So if they have absolute contraindications, they have to get off of blood thinners, then I think they're mostly protected because the appendage is gone. But if there is any other opportunity to bring them back to sinus rhythm by a catheter ablation or a combination of ablation and an antiarrhythmic drug, I would definitely push for that. So the last question of the evening is for Dr. Park. I mean, we heard a lot about the so-called plugs that can be put in from inside the Watchman device and other things. But people do talk about, as Dr. Kerber pointed out, the AtriClip or the Lariat and other things. And what's the role of these devices in clinical practice, Dr. Park, and when should we be thinking about those type of devices?
There has to be a lot of credit to you, DJ, because you've been pioneering in the field of using a Lariat in conjunction with ablation. We know that the left atrial appendage can also be an arrhythmiogenic source. So if you're able to eliminate the left atrial appendage, we're still waiting for all the data to come back, but that might also help maintain normal rhythm. The Lariat procedure is a very nice procedure in being able to exclude the appendage, and electrically as well as physically. And, I think that this is still research that needs to be borne out. But I do think we are in a very exciting time right now, especially with the next generation Watchman that's available, that has made the procedure even safer, and perhaps we can give this modality to more patients. There's going to be another research trial that's looking at using the Watchman in patients with a perceived lower CHA2DS2-VASc score, because the question becomes, what is better long-term? We know that people can only be compliant with these blood thinners for a short period of time, and then the compliance drops off significantly. And so the whole point of being on a blood thinner is if you don't take it, you're not protected, even with the NOACs. So there's a this is a very exciting field right now, and we have a lot more to learn.
Thank you. I thought this was a very informative and fantastic discussions about various aspects of atrial fibrillation. Thank you all for spending your afternoon with the rest of us and educating our patients on some important aspects of AFib. Thank you.
Thank you.
Invitation.
Thanks for having us.
Bye-bye.
Bye.
Bye.